All right. Good morning to India Tavi now. Can you hear us?
One second.
Yeah, Dr. Sharma, this is Bhupati here.
Bhupati, yes. And I saw Malik and Prashant and
with me-
Vijay. Lot of our
Yeah, with me, Dr. Maulik, Dr. Harish, Dr. Man, Dr. Vijay, Dr. Damodaran, Dr. Prashant there.
good.
Uh,
And I was told the meeting had been great success. Everybody, lot of
Yep.
attendance. And
we
then
got more than
us,
500 registrations.
yeah, us followed by West Coast, my friend Raj Makkar, then we'll end for the day. But let me, I mean, we'll introduce everyone in the room here. Better would be that we start with our presentation. Of course, Dr. Keeney on my right side, Sahil here on the left side as an interventionalist, Dr. Gilbert Tang, our cardiac surgeon, and then we have two fellows, the Manish and Rajiv, and then we have anesthesiologist, and then we have our echocardiographer, Stem Larakas. So we'll show, let's start the presentation. Little unusual case. We always try to make some point, and this patient, this actually start the first slide. I think the first slide should be that both the India now, this Tavi now summit from India, from Mount Sinai with Hydralazine Life Sciences and Sun Pharma. These are the players which I have mentioned, with Morgan Montgomery as the cardiac anesthesiologist, and we are all here to make this case, which is different in the sense this comes very common trouble in these patients with a high creatinine. Patient has CKD stage 4 and 5, creatinine is 1.8, 2.5, 3, and you still need to do the TAVI. What do you do? So this case is a 29 millimeter Sapien-3 Ultra Resilia valve in a low flow, low gradient severe AS with a CKD stage 4. Creatinine was 2.5 in this patient who is 90-year-old, has symptoms of heart failure and various the past medical history is shown there. Ejection fraction about 45%. Patient did have CLL with the chemotherapy and had a CRT-D, and medications is shown there. And more important is the TTE showed moderately decreased LV systolic function, and we'll show live with the severe low flow, low gradient of the 35-22 and SVI of 13 ml per meter square. Coronaries were non-obstructive. So if you go to the echo, but I think we'll show the live feed of the echo by Stem Larakas. Show
Yes,
the
sir.
echo, please.
Yes.
Yeah.
Good morning from New York. On my left, our structural fellow, Dr. Granot. As you can see here, a 4-chamber view, mid-esophageal, LV function about 40%. As Dr. Sharma said, RV is moderate dilated with moderate decreased function. The patient has an AICD, as you can see, dilated left atrium. This is a 2-chamber view. The posterior wall appears hypokinetic. This is a 4-chamber view. You can appreciate the severely calcified aortic valve, the huge atrium. Severe MR. I will show you some of the other valve lesions before I go to the aortic valve. This is a 3D of the mitral valve, surgical view, restricted posterior leaflet, thickened leaflets, dilated annulus, MR because of severe mitral regurgitation.
Oh, it's severe now, because earlier was read as a moderate plus only, yes. But severe, okay.
Severe MR. Mild tricuspid regurgitation. The PA pressure is about 40 millimeters mercury, mild pulmonary hypertension. And coming to the aortic valve now, as you can see, short axis view, severely calcified aortic valve, decreased motion of the leaflets, mild aortic regurgitation. Long axis view now, again, thickened leaflets, restricted motion, mild to moderate maybe aortic regurgitation. The gradient that we got here today, peak velocity 2.8, maximum graded 32, mean graded 18, a little bit lower than what we get with the transthoracic echo. But the aortic valve comes again severe aortic valve area 0.6 centimeters square, stroke volume index about 15, low flow, low gradient, classical low flow, low gradient aortic stenosis. Because of the problems with the dye of this patient with renal failure, we did the 3D. As you can see, the annulus, oval annulus, area of 6.5 centimeters square. And we measure the height of the coronaries. This is the left main height, 1.3. Got a little bit out of the order here. Severely, again, calcified aortic valve. These are the measurements of the sound-tubular junction and the sinus of Valsalva 3.8, sound-tubular junction 3.5, and the height of the right coronary of 1.5 centimeter. Thank you very much.
Okay, so key was in this case because of high creatinine. Otherwise the workup of Tavi now has become straightforward. You decide, of course, by echo the patient is appropriate. Then you do a CT, and you all your parameters with the 3-man show is all set. But now, if you have high creatinine and you cannot give contrast, that's where it becomes the challenge. So this patient was planned, intubated. The TE gives those measurements. So Gilbert, you want to comment on that?
Yeah, so we like to compare the TEE with, if you do a non-contrast, there's no contrast, it's much harder to estimate the annulus. So we also do a cardiac MRI to actually define the annular sizing, because obviously if you use a balloon expandable valve, you want to avoid any kind of rupture. Or, you can, but with self-expanding valve, you have to oversize adequately. So I think we now do multi-modality imaging.
So because of high creatinine, at the time of procedure, you will do measurements with the TE, but otherwise it will be a non-contrast CT and MRI.
Correct.
So MRI will add what in addition to the non-contrast CT?
So MRI allows you to do annular sizing more accurately. You can look at LVOT as well, and actually some of the left main and root measurements are also good.
Okay. So what about our creatinine protocol? I mean, Sahil, the patients with high creatinine, how do we work them up and what is our cutoff?
Right, Dr. Sharma. So there's no predefined cutoff just by the creatinine number. It's by GFR. If your GFR is less than 30, we go for low contrast CT scan. We always want to see that we can get a good, the gold standard is the CT scan. So if we can get a CT scan, that's the best. So we can do around 30 cc contrast. If the creatinine is really less than 15, then there is absolutely no chance, especially in a 90-year-old with a creatinine of around 3, your GFR is so low, it's unsafe to do a CT scan. So in those situations, we will do MRI and a non-con CT scan. MRI can be sometimes tricky because if you're deciding between balloon expandable and self-expandable valves and you really don't have clear-cut annulus sizing, then we'll add on a T measurement to corroborate what we think would be the best strategy.
Okay. Anu, this is your patient. How convinced the patient was with the symptoms, in this case with the high creatinine and so many other things going on at age of 90, moderate LV dysfunction and low flow, low gradient. That question always comes, truly symptoms from AS or symptoms from many other things in these elderly patients.
So this patient we've been following up for years. I actually first saw her over 2 years ago and was not too convinced, did not want to proceed with the TAVR, and at that time was only moderate MR. Managed her on medical therapy, but I think over the last 6 months has had multiple admissions and also getting progressively worse. So even though she's 90, she's totally self-dependent, doing her lives alone and takes care of herself. And then finally, she herself is now convinced that she wants this procedure, and also family has agreed that I think proceed, even though with the high risk. So with this kind of thing, so always discussion is no matter what, with that low GFR, that's a risk of still going on to dialysis. So this was well discussed with her and the family. Everybody understood the risk and the risk of the TAVR procedure, especially of the stroke at this age. And after the family discussion with the heart team, with our surgeon, everyone agreed that we should proceed with the TAVR.
And clearly, if there is a both severe AS and moderate to severe MR, we'll tackle the AS first, right? Everybody agrees on that?
That's for sure. Hoping that with fixing the AS, now the severe MR should go back to probably moderate, that we can manage on medications.
And even if it remains, then after a few months, you can think about the mitral clip. Right? Our panelists, and what's your opinion, guys, in that?
Exactly, we agree with your plan, Dr. Sharma.
Beautiful. Okay, let's go quickly because then we go to the real. This is our cardiac MR.
Yeah, so you can see, cardiac MR actually is pretty good in terms of definitions on the annulus, and most particularly is LVOT, because you cannot see LVOT on the non-con CT. And so this is pretty much a consistent with you can see the non-con CT is a little bit smaller, so you have to compare. And that's kind of when you decide one valve versus the other. But you can see pretty consistent within the 29 balloon expandable valve range. Next slide. Next slide. And you can see how you can do a 1 millimeter cut measure. Next slide, in terms of just look at the morphology. On MRI, the leaflets that calcify are black. Next slide. Versus white and non-con CT. So you can see that it matches nicely. And the calcium burden on the non-con CT, as Dr. Keeney mentioned, is very heavy. This is a high calcium score. So despite classical low flow, low gradient, this would be a treatable patient. So this will benefit the patient 100%. And in fact, if there's reversible remodeling, the EF might even improve actually after fixing the ES. Next slide, please. So you can see we're correlating the STJ and the sinuses. Next slide. Very big root anatomy, pretty consistent. Next slide. And the coronary height, as Stan mentioned, are pretty consistent. Next slide.
Yeah, very good. Echo and the coronary height
And
slide.
so you can see that as well. So low risk of coronary obstruction. Next slide.
And I know the question came up that remember if the simple principle, height less than 10, sinus less than 30, if the data shows obstruction about 8%. If one of them is present, then about 4%. None of them are present, then less than 1%. And more with the balloon expandable versus self-expanding valve for the coronary obstruction.
Yeah, and you can see the calcium burden. We like to look at that on the non-con CT. Access, Sahil, how was the access? You want to comment?
Yeah, this is a pretty challenging case. The vessel is almost 15 centimeters deep to the surface. It's an extremely obese patient, but so far so good. Large caliber vessels, not much calcium, so should be a percutaneous case.
So basically summary is, this is the patient, 90-year-old, CKD stage 4 or 5, with the plan is with a 29 millimeter Sapien-3 Ultra Resilia. And we'll just talk about Resilia in 1 second. And Sentinel cerebral embolic protection device, which have been done with a minimum contrast use. The minimum basically means that keep it in single digits. 8 to 10 cc's total will be in the case. Now, what is Resilia? As we know, when we are getting into the younger age, we are comparing against surgical valve. The biggest degeneration happened because of calcification of the valve. Sometimes PVL, sometimes patient prostate is mismatched, but calcification is the biggest. And of course, the Edward team has this very unique the technique reducing calcification, which is the Resilia tissue, which have been studied. There's a whole, glycosylation, and this actually have been studied quite a bit in the surgical valve. And the data have been very consistent that very low degeneration and very low calcification of the valve, and show many of the data have shown the structural valve deterioration at 5 years is almost 0%, even further on. So clearly the Resilia, I know it's not available in India yet, but I can guarantee you by year end it will come there, and particularly useful for younger people. So when we are saying the valve will last 10 years, I think that will be the history, because this valve can last 20 years as long as there is no PVL and patient prosthetic mismatch. So this is the new field, and I know that some of this technology come a little late in India, but we are pushing it to bring it as much as there. There is slight cost to it, few $1,000s. But I'm sure with the Indian subcontinent, they may keep the same price. But yes, this is a new addition to the current Tavi of the Sapien. So with that note, tell us now how we are going to do this case without very minimal dye. They're given 2 cc's of dye now.
Point that we want to also make is, we have a Sentinel, you mentioned, right?
Yeah. Sentinel has been done. Show the fluoro now. Let's go to live.
So Sentinel has only been done in one vessel because of extreme tortuosity. But we think that patients who have calcium score more than 3,000 on the valve, they should get Sentinel irrespective, because it does prevent disabling strokes, and we have seen that. So we try to do Sentinel in these patients. This is extremely tortuous vessel. There was a small takeoff ostia of the carotid, so we said best to at least cover one of the arches.
And then we have to show that Olympic ring sign with the 2 pigtail to show our base of the aortic valve once the time will come, right?
We did it with the one wire, and other one was a pigtail.
Yes, you can see there's a huge calcified burden on the left cusp, so you can use as a landmark. And we typically put a pigtail on the right cusp through, and then put a J wire to the non-cusp, and then you line up the 3. And we actually did a little small hand injection just to show the audience the angle. Right there.
Yeah.
So you can see it's pretty.
This is the 2 cc's of dye so far. Yeah. Beautiful. Okay, let's cross it.
Yeah. Now the question is,
concerned about the temporary pacemaker, Dr. Sahil and Dr. Keeney.
Yes, I understand. Yes.
Position.
Yeah. So let's go to this view. See,
That's a good point. So sometimes what happens in these patients is it tends to sort of fall out. Remember, it's a big
but in
patient.
RAO view, it looks okay.
Yeah, so what we'll do is we'll just gently push it forward and we can test
inflate?
run it once.
You want to inflate balloon or no?
Not
We
yet.
should be okay.
Half
Can you
inflation
test
May
for a
go-
second?
It may fly out.
Take the
Tip.
180.
150 and 1.
Yeah.
Okay, disconnect.
I think you need to little balloon inflation. You have to advance a little bit. Slight balloon, half ceased.
It's not even going to the apex.
Good.
Very good point, Bhupati. Yeah, I know in the LAO was little. Okay, now you want to do it?
Pace 150. Disconnect.
Good. Okay, very
Okay,
good.
now
All right.
pace. Let's see.
Done.
It may still move.
Okay,
You
we'll
go.
see.
You
All
put
right,
it.
let's go.
Okay.
Yes,
Now
that's
we
a
are
good
ready
point.
We have AR2.
55.
Yeah. So now based on the aogram, just the small we have,
Far from the
I was thinking AR2 may not be the. We have a AR2 catheter, but we may need AL1
Okay,
to cross.
let's try this
see.
first.
I have another question
Hello.
to
Yes,
the team
yes.
there.
Yeah, yeah.
Uh,
Keep asking.
what did we
yes.
do with the ICD? We have we
Yeah,
switched
put
it
a
off?
magnet there. There's a magnet
Yes.
there.
Yeah,
Yeah.
we switched it off.
There is a
I'll
magnet.
show
yes.
it to you here.
Yeah.
So that's a routine. Our anesthesia colleagues they put the magnet there, and we have the pacemaker.
Hello.
This is the additional
nice.
protection anyway. I mean, there will be some. We need to come up with some simpler thing. I know there is a lot of with that wire, pacing wire, which is quite a bit taking. Gilbert, what's happening with that pacing wire?
Well, I think the challenge that pacing wire has some design that might need some
Beautiful.
modification because there been some issue with the where the sensing is and where the pressure is, and then also if you need to pull back the wire to release a valve, you cannot do that with pacing. So because I don't think we really save a lot, and it's actually costs more.
Very costly, very costly.
So I think we still prefer the right
Can we
TVP.
put the hemodynamics by the side?
Also, if the patient develop complete heart block, you really don't have other bailout option
Yeah.
in terms of removing the wire.
Scalpel.
So very high gradient.
You might actually look at the high gradient. It's not a low
Yeah.
flow, low gradient here.
Should we pre-dilate just to make the valve crossing
yeah,
easier?
right. Yeah. So because
I
we are
don't
let's do
think
that.
so.
Huh?
Yeah.
What?
No need.
No, but there's very
Let's-
calcified on the,
Yeah.
the cusp,
It's
on the
okay.
echo
We
as
don't
well.
have a send. Yeah.
Yeah. Well, I think we
Huh?
should just
Oh, okay.
Yeah.
We do it.
Yeah.
right?
Oh, yeah.
Yeah.
We'll do it.
What? Yeah. 22. Yeah.
Okay, so question always comes the pre-dilatation, and I think you can take the opinion of our panel there and maybe the audience that how many people do pre-dilatation with the self-expanding versus balloon expandable, and then we can tell you our data. And this is the case since we are deciding the balloon expandable Resilia. So we very calcific, tight valve. So we decided to do a pre-dilatation. And now particularly also that we don't have a full coverage of the Sentinel.
That was the reason I said try
So
not
that's
to.
why
avoid
the reason why that we know that a lot of data have shown your balloon dilatation where the time of TAVR is associated with slightly higher stroke rate. And but in this case, I think with such a high gradient calcium, it's reasonable to dilate with what size you are using?
23 true. That's all. I have.
23 true balloon.
Yeah.
Right?
22 true,
Yeah,
even better.
22 true balloon.
Yeah. You just need to
How did
dilate enough
you
to cross
manage
the
this
valve.
Patient with atrial fibrillation, he should have been on anticoagulation. Did you bridge or what was the protocol that was followed in this particular patient, Dr. Sharma?
excellent question.
Yeah. No, so the patient is already on NOAC. I think that's a very good point. So Bhupati, any patient who has charged VASC more than 5, they get admitted a night before and they're transitioned to heparin. They usually stop their Eliquis day prior.
Yeah. One day prior. So idea is
The
with
high-risk patients.
long-term discontinuation of more than 3 days is trouble.
Yeah.
We looked into our data. So we try to do off one day. And those who have stroke rate or higher CHAD score, we admit night before and bridge with heparin. If not, we just step 48 hours and bring that morning. So somebody with never had a CVA before, otherwise young. So it doesn't need every patient need to be bridged, but those who are high risk definitely should be bridged. Very good point, Bhupati, because we saw that once they were off 3+ days, there were higher chances of CVA with the post hour.
And stop the NOAC only for 24 hours.
Yep. Yeah. And Maulik, what about your, let's talk about the data of Sentinel use in India. I know that because of cost clearly and not a very convincing data, a lot of people are like sitting on the fence using. We used to use 65, 30, 67%. Now about 40, 45, the type of cases with the prior stroke, bicuspid valve, valve and valve, and those were using it.
Use some Tegadum.
Yeah. So Sentinel, we use it in patients. So it's as you know, sir, it's a out-of-pocket expense in India, and it adds to the overall cost of the procedure. So what our practice is that we offer it to patients. I mean, sometimes when you're doing a patient who wants all the safety aspects first and not talking about the cost of the procedure, we definitely offer to the patient. I offer it to every patient, and I give them a choice that with the device, the risk of stroke becomes very low, but not zero.
Yep.
Must set the expectation right. And we try to use it and pursue the patients, especially if it is a heavily calcified valve or there's a lot of calcification on the at the base of the neck vessels in the ascending aorta, or in the heavily degenerated valve-in-valve cases. We try to use them and we try to pursue the patient more in these patients selectively. But otherwise, we do try to offer it to the patients at least, and then they may or may not opt to use it.
To go a little further, but even TVT registry is a small number here.
Actually, it's around like 15%.
Yeah, 15 to 18% in America.
Yeah,
this was before the PROTECT trial.
Good.
That was before. Now maybe even lower. So even in America, as Maulik and the Bhupati and others were on the panel, India is not doing anything unusual. That even in America, where there is reimbursable, you get about $3,000 payment. The device cost about $3,200, $3,500. But it's still used in teens, between 15 to 18%. And that was pre-PROTECT trial data. After PROTECT, maybe it will go down even further.
Yeah, I mean, sir, we are in India worried about when there is a stroke in a patient who you used all the best products. And when the patient comes and tells you a few days later, doctor, could we have done anything to prevent it? So that's why we have started offering it to the patients.
Beautiful. Yep.
Yeah, no, I think that's a very good point. One more thing I would like to say is, Dr. Sharma and I have discussed many times, the patient population in India is very different from the patient population we see here. There's less calcific bicuspid disease. 40% of patients are bicuspid, but fibrotic bicuspid or rheumatic bicuspid, not like the calcified late-stage bicuspids we see. So that's another thing why the stroke rates are actually low despite not using Sentinel in India. I think the lowest stroke rates are in India.
Sahil, I couldn't agree more. I mean, in our institute, 150 patients of TAVR, touchwood, our stroke rate is 0. So, and you're right, the more of fibrotic patients are relatively younger. So, yes.
So, and actually, that's absolutely correct. Yes. Yep.
Dr. Sharma, Harish here.
Yes, Harish.
So how do you quantify stroke in your practice? Do you go only for massive stroke, or you have other modalities to even say cognitively the patient has changed post-TAVR?
Valve is crossed.
Any transcranial Dopplers or anything?
Yeah, very important point. So clearly, every study have shown that where you have a protocol that patients get pre and post-TAVR neurology consultation. So the stroke rates are much higher. Their paper recently published from Michigan. And so same thing from our side, that we have a set right from the beginning. We have a neurologist pre and post. And of course, any defect which we are not going with just some cognitive, but truly neurosensory dysfunction. And then
nominal, right?
And the diagnosed with the MRI. So that's how we'll make, immediately you do a CAT scan, many times it is negative, but ultimate will be the MRI. So it is done by the protocol, not that only if there are symptoms, and studies have shown the stroke rate is half if you don't go with the protocol and only do when there is a symptom.
33 ml in 29.
How often we are using Ultra these days? It's all Resilia?
Ultra, I would say about 1/3, just because still there is a nominal $2,000 cost difference between regular and this.
No, Resilia is 1/3.
Yeah, Resilia. So Resilia, Resilia Ultra, all are the Ultra Resilia is about $2,000 difference. So we use in about 1/3 of cases, particularly young patient.
Okay, 180.
Okay. Yep. If they're doing it, see, without dye, and we're looking good.
Off.
Another 2 cc,
Very
so
little.
2 and 2,
Yeah.
4 cc so far, and looks very good. Now you pull back your pigtail, and we know if your contrast volume is total less than 10, single digit, no matter whether creatinine was 5.4, will not even go to 5.5.
So this Resilia is a slightly stiffer valve to inflate. Okay, so we're going to inflate, you'll see us, and then we were planning to do 2 inflations. Ready? Good. 180. Go slow. And now full. Fully inflated. Okay, come down. Not yet. Okay. Off.
Off pacer.
Good.
Let it recover. Resuscitate, please. Good. Yeah.
Yeah. The other thing is that remember the 29 Sapien-3, there's no ultra. So the next step, if you want the enhanced ceiling skirt, is Resilia.
Yeah.
And that's why we choose this valve here, because we feel that this enhanced ceiling skirt does make a difference on paravalvular leak.
And that will be the valve in
You
India
wanted to
also
see
now.
TE or we just will go second?
No, one
we
more.
should
One
go
more.
one more inflation.
Okay.
Yeah,
We're
Resilia,
just
we
going.
always have said, so it's a little thicker valve, or need a second inflation. And that's okay, which we do otherwise also. I'm believer of the 2 inflation for all the balloon expandable. And I think second inflation do better job. Just like I do it for the stent. We started the practice decades ago.
Okay,
and I'm
good.
still putting it-
180.
Sir,
180.
would you not check a transesophageal echo since
No,
you already have
no,
it there
no,
before the second inflation?
No, I think it just do a better inflation, just like it does for the stent expansion.
Yes.
So I remember the recoil is coming quite a bit. There are some papers now. There are some small reports of the second inflation, keeping it a lower gradient at follow-up.
Okay. Off. You want to take out the wire?
Wire out.
No. We do a pigtail.
Okay.
We do a pigtail. Yeah. So question comes,
Okay, off.
not every case. Let's say very patient more with the AI. Patient has a less calcium.
Ready?
I think 1 inflation is good. But in other situations, you have to do 2. Valve in valve. You're doing a balloon expandable, we always will do a 2 inflation. So some situations 2. And there are papers now. I can tell you, I believed in this few years ago, and we are doing it anecdotally, but now coming that 2 inflation may be better. Not in every case, but Gilbert, you want to comment on that?
Yeah, we might actually looking at yesterday we did a case where the second inflation clearly expanded the valve. There's a little bit of recoil, just like any kind of stent, balloon expandable stent that you would be using. So we feel that by optimizing the frame expansion, not paravalvular leak, that you actually improve the hemodynamic and maybe even durability, because there's a recent CT paper that showed that if you have underexpanded valve, whichever valve it is, you have less durability, more hull, and actually increased mortality now.
All right, before we show the hemodynamic, show us the echo. Bring the echo on the main screen, please.
Yeah, the echo looks great. We
Yeah,
did
show it.
already the.
Flush both.
Yeah, we are. And
Okay, echo on the main screen, please. Good.
We go 81,
See it to
81.
believe it. This is because there is very little dye or everything echo.
Come out to show the mid-esophageal.
So we'll not have an aortogram.
Yeah, no need for aortogram. Yeah.
Okay, open the.
If you want, we can give 2 more cc. Just
No.
2.
No.
No.
So this
two.
mid-esophageal,
Community show they're very
as you
good
can see, good position of the
without
valve.
that. Yeah.
Yeah.
Flush.
1 second.
No,
Safe.
maybe trivial
Ah.
PVL, minimal.
Let's zero everything, please.
Let's go short axis.
Zero everything.
Short
I think
axis
MR has
looks,
gone down.
Let's see.
looks beautiful.
0. Not 0 yet.
Nothing there.
Zero, please.
0.
Blue and
Let's
yellow
go in the
channels.
stomach.
Okay.
Yep.
The stomach, yeah.
I mean, I can tell you that will be remarkable.
Show
in
us
this
the
lady if
color.
the MR becomes 2+.
Okay, keep it there.
Good.
Circular,
Yeah.
right?
Okay,
Yes.
nothing, no PVL, nothing.
Same small amount will do.
You see the
there.
gradient.
Wow. But tell us about the MR now.
Gradient of 5, peak gradient of 5.
5. Very good. Means a 0, which will show the hemodynamics.
Okay, let's see
Echocardiography.
Let's see
No,
the
high
let's
fade
ask
will
the
come out to see
people.
the MR.
Would anybody do aortogram or were
MR.
they happy
No,
with this?
we want to
Wait.
do aortogram.
Let's see the MR now.
We had to just this single digit 10 cc.
Yeah, this-
Yep. MR is how much now?
Maybe a little bit less, maybe moderate to severe, from severe, moderate to severe.
Oh, good.
MR is a
Acute.
grade down.
Beautiful.
Yeah,
Wow.
down.
Good. 1+
And how's
down.
the ejection
Right away.
fraction, Stam? Is it the
Ejection fraction looks a little bit better here. Maybe 55, 60 now from 45
Advanced little bit.
before. So as you can see, improvement. Everything looks much better
Wow.
after this valve.
Okay,
This to contrast.
good. Okay, now let's take the, show hemodynamic.
Oh,
Show
okay.
that.
Yeah, so
1 second. Look at the hemodynamics now. Echo is done. Show the hemodynamics. Zero gradient. Remember 5 to 8 becomes 0 and diastolic pressure is good. So no regurgitation. Already has been confirmed by echo. Okay, now fluoro. Take your pigtail back. T probe up, please.
Yes.
Now what I say that we will not, we are going to show another those same 2 cc's of the dye, which we don't do otherwise, but I think just to
Prime it.
emphasize of this point, that valve is in very good position. We don't need it. But I think since audience is there, echocardiographer, echo believer, but I know Anu is saying don't do it, but I think we do it for the our summit. Let's see it. Give 2 cc's. So we still need to remain in single digits. Yeah, just go. Reluctantly go, Anu. Good.
beautiful.
Beautiful position.
Yeah.
I
You
didn't
see
press it. I asked the fellow press it.
All right, guys. Tell us any other questions about this.
So I'm Sahil, would you consider LA appendage closure here if MR goes down?
Yeah, no, it's a very tough question. I mean, she's 90 years old. I'm not sure how much that's going to benefit longitudinally, but I think what happens in these patients also, if they start developing atrial SMR, then it becomes very tricky because you might close, but if you do not fix the MR or do not help the AFib, atrial myopathy just continues to dilate the appendage. And we've seen a lot of leaks come back because of atrial SMR. So that's a very tricky question. Definitely, we have to sit with the patient and decide. Because remember, it's not a therapeutic procedure, it's a preventive procedure. Any complication in a preventive procedure is really painful to swallow.
Well, any other question from our panelist audience? Anybody can come to the...
Any questions from audience, panelists?
Would you ever do these techniques, contrastless, without TEE, which means no need for GA? Or to be on the safety side, TEE is...
Yeah, you can. I think certainly valve in valve for sure. You don't need the TEE for that, unless there's some underlying reason. And also, if you have a very good quality non-con CT and MRI, we've done it without TEE as well. But this in a 90-year-old, we just felt that it's better not to have any rupture or any other complication from the procedure.
So Gilbert, this is Vijay Iyer. Would you consider doing this with 4D ICE?
So as you know, aortic valve with 4D ICE has not been published a report, but people have done it. But usually you would do it only to evaluate paravalvular leak, which I think it's not for procedural guidance or positioning, because everything is pretty much by fluoro, and you can look at fluoroscopic landmark. So I would, because of cost reasons, I think would not been kind of a standard to do a 4D ICE.
And so far, there's no report. I didn't see any report of that.
It has been done in some case reports, but again, no standardized protocols exist. And aortic valve via ICE is not probably the best pathology to visualize.
For the mitral tricuspid is very good.
Yes.
Okay. All right. Any
And
other
even
questions?
the appendage occlusion.
Dr. Samin Sharma, this is Dr. Anand Rao.
Yes, Anand.
If this is kind of pictures you get, then why can't this be like a standard of care to all the patients with less dye and MR for analyzing? Why can't it be done to all the patients?
Very good point. But I think the precision, which one CT angio, where you do evaluate your 3-man show, I think that 70 cc of dye makes the picture right from above to below very clear. So that's basically the reason. I think we do modified, but that require multiple steps. Look at this case. Needed TE, needed MR. If one CAT scan could have been done in patient with a normal creatinine, if you would have done everything, groin access, you're always questionable, how you see it, and so on. So later, lot of issues. So question is, can you do otherwise? I think this is, to me, should not be the standard of care. Should be the standard of care in patient with the CKD stage 3 and 4 and above, maybe 4, but 3 I think still should try. And many times we bring the patient night before hydration, then give a low contrast CT, and that will give us a still good picture, 30 cc. So regular one, as you know, use 70, 75, low contrast about 30, and then what we have done so far was pre-workup, zero contrast on the CT, and the MRI, take an additional procedure done for patient. Now here patient got TEE, and then we still were concerned, because you are not 100% sure. Why? Because you are 100% sure what you do routinely all the time. Practice makes perfect. That's how we learn on this 3 mensio, and you are done with the procedure. So just because of that, I would say this should be as a bailout, or I would say second line workup rather than the first line workup.
So Dr. Sharma, you have got 5 more minutes. Dr. Sai, would you like to capture the Sentinel and show the audience?
Hello? Yes,
Sure. Yeah, why not?
Why not? Absolutely.
Yeah, I'll just add to Dr. Sharma while Sahil's setting up removing Sentinel that when you're non-contrast CT for access, if you have calcium, you actually may overestimate your vessel size. So you have to be very careful that you have borderline access using a non-con CT, that the vessel size may not be adequate in the presence of significant calcification. So just keep that in mind.
That we made a logic on that. So, but yes, the whole purpose is we need to devise the strategy in every patient. So this is keep it for your 20% of cases. Extra effort, but yet